Right, so starting off with this section on joints. So just to run through what we're going to look at in this section then is we're going to understand the joints of the skeleton. We'll describe the classifications of joints. Then we'll look in detail at the structure of a synovial joint. We'll describe the types of synovial joints and their range of motion. Then we're going to look at joint actions, and then at the end we're going to look at the life course of the musculoskeletal system and its implications for special populations and exercise. Okay, so joint classifications. Can anybody tell me what the different joint classifications are? Or what is a joint, first of all? What is a joint?
Bone meets another bone.
Yep, simple as that. So a joint is simply where a bone meets another bone. Okay. There are 3 classifications of joints. Can anybody tell me what they are? Three classifications, 3 types of joints, or not types. Yeah,
one synovial.
Synovial is one, yes.
Is fibrous and cartilaginous. Is that it? Yeah.
Yeah, that's it. Good stuff. Okay. So first of all, fibrous. No, that's right. You got it. So fibrous, first of all, so is immovable and interlocking bones such as the plates in the skull. So where those plates in the skull meet, we've got a joint because it's where one bone meets another bone, but it's a fibrous joint because there's no movement in between those bones. Can anybody tell me where we might also find fibrous joints or immovable joints? Okay, so if we think at the bottom 2 sections of the spine,
pelvis,
not so much the pelvis, but between the bottom 2 sections of the spine. Sorry, let me just make sure you can see
the bottom 2 sections. You've got that's your thoracic. You've got your lumbar, and
so down here.
Sarcal.
So the sacral,
sacral and coccygeal.
Yeah. So we've got 5 sacral and 4 coccygeal bones. Okay, and they are fibrous joints. So we've got 5 individual sacral bones and 4 individual coccygeal bones, but there's no movement between these. So they are fused joints, fibrous joints. Okay, down at the base of the spine. Okay. So the second one that you mentioned then was cartilaginous. So our cartilaginous are slightly movable joints. Okay, so slightly movable bones brought together by ligaments. So for example, the vertebrae. So there is some movement between the vertebrae, but not as much as our synovial freely movable joints. So these are the most common type, having the following characteristics. So the ends of the bone are covered with hyaline cartilage or articular cartilage, so allowing for friction-free movement. They're stabilized by ligaments. They're surrounded by a fibrous capsule, and the capsule is lined by a synovial membrane that secretes synovial fluid as lubrication for that joint. So what we can say is we've got a freely movable joint, a slightly movable joint, and a totally immovable joint. Okay, so our synovial joints are freely movable, our cartilaginous are slightly movable, and our fibrous joints are our immovable joints. Okay, so to look a bit more in detail at our synovial joints, because obviously when it comes to exercise and it comes to movement, we are using those synovial joints. So the articular cartilage lines the ends of the bone for smooth movement, so for friction-free movement. So if we didn't have that cartilage at the end of the bones, we'd get a lot of friction, a lot of wear and tear on the bones themselves. So that cartilage is like a rubber sheath that allows for that friction-free movement. It also helps with shock absorption. So if we think about the bones around the knee joint, if we jump and land and then those bones were to kind of crash on top of each other, that cartilage helps to absorb that shock and that impact if those bones were to knock against each other. The joint capsule is a sleeve-like capsule that encloses the whole joint cavity. Okay, let me use. So we've got the elbow joint here. So we've got a capsule that surrounds that joint. And within that capsule, then we've got a synovial membrane. So we've got the capsule that surrounds the joint. The membrane will secrete synovial fluid into the joint. And that synovial fluid will lubricate the joint, kind of like an oil and a lubrication, to help it to move freely and smoothly. So ligaments will link bone to bone. So if we've got our elbow joint here, we've got a ligament that will run down, crossing the joint to help stabilize that joint. So prevents any movement side to side. Your elbow is not able to do this movement. It can only do our flexion and extension movement at the elbow joint. So those ligaments will help to stabilize and maintain the joint action. Tendons will attach the muscle to the bone. So if we've got our bicep muscle running down along our humerus here, the tendon will cross the joint onto the radius and ulna and then pull on it, creating that movement. So the tendons will cross the joint to attach onto the lower bone. Okay, and it looks a little bit like this. So what we've got here, and let me just get my pointer up. Okay, so what we've got here then is a bone meets another bone, so it's a joint. So this is an example of a synovial joint. We've got the ligament that attaches the bone to bone, so giving it its stability. So bone to bone on either side, a ligament. We've got our articular cartilage that covers the ends of the bone. So without that, we would have a lot of friction and wear and tear on the bone, and it helps with shock absorption when it comes to impact. We've got the synovial membrane on the inside, and that's what secretes synovial fluid into the joint. So an oil into the joint that helps with that free movement. On this diagram as well, we've also got the periosteum. Now the periosteum will start around here but move down the shaft of the bone. So the periosteum does not cover the epiphyses, it only covers the shaft of the bone. And it's where our tendon will cross the joint and attach onto the periosteum. Okay, so our synovial joint, so if we look at the elbow joint here, where we've got our, bear with me. Do that. Okay, so we've got our synovial joint. So our ligaments will cross the joint, allowing stability. Our tendon will cross the joint onto the periosteum of the lower bone to help with joint movement. We've got our cartilage, which will line the ends of the bone to help with friction-free movement and help with shock absorption. And then that whole cavity with the synovial membrane has got our synovial fluid inside it to help with that free movement of the joint. Okay with that? Any questions? Okay. Okay. So different joint types then. Can anybody tell me what different joint types we might have? 8 types of joints.
Ball and socket.
Ball and socket's one, yes. Anybody
Hinge.
else? Hinge, yes.
Pivot.
Pivot. Gliding. So we've got gliding joints, pivot joints, saddle, ball and socket, ellipsoid, and hinge joints. Okay, so these are the different types of joints that we need to look at, and we need to know where they are located as well. So first of all, we've got our gliding joint. Now, as we can see in the picture here, this is so these bones here are our carpals, okay, within the wrist. So as we can see, they're kind of cube-shaped bones. They're short bones, where we've got our short bones, and what they do is rather than opening and closing, they will simply glide past each other. Okay, so a gliding joint, which is where they will kind of move side to side and up and down. So they don't open and close, they will simply slide along. So as you move your wrist around like this, those bones inside there are simply sliding around past each other. So our gliding joint. So as it kind of says on the tin, it glides past each other. If I go too quick through these, shout, okay, and I can go back to them. If you've got any questions, obviously shout as well. Okay. Our hinge joint, So for our example here, we've got the elbow joint. So a hinge joint where we open and close the joint. So at the elbow joint, which we've got here, so we've got an open and close elbow joint. Oh, God. Open and close hinge joint. Okay, everybody happy with that? Where else do you think we would have a hinge joint?
Wouldn't it be the knee?
Knee, yeah. So in the knee joint, again, it just opens and closes. We've got the knee joint. So our hinge, like a door hinge, opens and closes. A pivot joint. Okay, so the example here is the elbow joint. Okay, but more particular, it's the radio-ulnar joint. So if I show it to you here, so this is our elbow joint here between the humerus and the ulna. But what we've actually got is our pivot joint, and let me show you that, which is here, which is between the radius and ulna. I'll take away the humerus and show you what I mean in a bit more detail. So as we've got it here, it rotates around. So when you do pronation, so we turn our palm from palm up to palm down, it happens at the elbow, okay, at this point here, where the radius will rotate over the ulna. Okay, so it looks like this. So we've got a pivot joint at this area here. Can you see that? Okay, so we've got that pivot joint. If I put his humerus back on. Excuse me. Okay, so now we've got our elbow joint, but when we do pronation, supination of the arm, it happens up at the elbow where we've got that pivot joint. Can you see that? Okay, so our pivot joint at the elbow. We've also got another pivot joint, and we mentioned it earlier on.
Is that at the atlas?
Good, yes. So the atlas and axis. So cervical vertebrae number 1, cervical vertebrae number 2, where we've got a pivot movement where we can rotate at the skull. Okay. Ball and socket joint. So as we can see here, we've got our ball that sits into the socket. This is the shoulder joint. Okay, where else do you think we would have a ball and socket joint?
That'd be on the hip.
At the hip, yes. So lots and lots of movement, lots of muscle attachment across this joint here, where we've got loads of different types of movement. So if we think about the shoulder joint, the amount of different movement you can do at the shoulder joint, because that ball sitting into the socket allows for lots and lots of different movements to occur. Okay, so the shoulder joint and the hip joint is where we've got our ball and socket. A saddle joint. Okay, so as this kind of says, it looks like a saddle. Okay, so we've got it in the knuckles of the fingers. Okay, so where our saddle, one just sits in to the other. So there's not loads of movement. There's more kind of flexion, extension, little bit of circumduction that happens at the knuckle joint here. Okay, so toes as well will happen. So the knuckles of the toes and the knuckles of the phalanges and the metacarpals. Ellipsoid joint. So this is where we've got, again, within the fingers and the toes, an ellipsoid joint. It looks a little bit like a ball and socket joint, but nowhere near the amount of movement that we've got in an actual ball and socket joint. So the ellipsoid joint here. Okay. Oh, that's it. Okay. If I show you this saddle joint, actually, it happens at the thumb. So our saddle joint. Let me show you the thumb here. Okay, so this joint, this joint here is our saddle joint. So I don't know if you can see how it kind of looks like a little bit of a saddle. See that behind it. Sitting on top of the other one. And then our ellipsoid joint would be down into the knuckles down here. Okay, you don't really need to know too much about these ones, okay, because obviously they're not involved too much with exercise or movement, but it's just to be aware of those types of joints that we've got. So ellipsoid and saddle. Okay, but the main ones that we're going to be focusing on are our ball and socket, our hinge joints, our pivot joints, are the main ones that we're looking at, our gliding joints. Okay, joint actions. Now, what I've got with this section is 4 videos YouTube videos. I'm going to play one for you. I won't play them all because you can watch them in your own time, but it's going to go through the joint actions that you will need to know for the qualification. Just bear with me 2 seconds. I'll get this up and running. Don't do it. Okay. Oh, can you guys hear that?
Not got any sound.
No sound. Okay, bear with me 2 seconds. Oh. Anything?
No.
No? Okay. Why would that work? Bear with me 2 seconds. I'm just going to stop sharing and then try and share this page. Don't you love technology? Anything? No? Anything there? No. Okay. I'm not too sure why we're not getting sound on that.
So as I go through the list, make sure you practice the movements with me and say the names out loud.
Let me just start it again. See if that works.
We are now going to learn the correct names to describe joint movements. But here's a warning. There are many names to learn, but they can be easily grouped together, much like when you learned their anatomical positions. So as I go through the list, make sure you practice the movements with me and say the names out loud so as to really anchor them into your memory. The first set of joint movements that we're going to look at are the words flexion and extension. So flexion means to make the angle smaller and extension means to make the angle bigger. So some examples are, here at the elbow, when I pull up like this is elbow flexion. We also have hip flexion, and then this would be knee flexion. Making the angles bigger or extending them out is considered extension. So elbow extension, hip extension, and the knee is already in an extended position. Hyperextension. So this is a bit more tricky to demonstrate, but examples would be elbow hyperextension, and this is where you would see the elbow actually kick up like this. Other places for hyperextension are in the knees, and you'll see that from the side when people's knees go behind them. Lateral flexion. We often use this just for the head and for the trunk. So for example, when my head goes this way, that is lateral flexion, or my torso, that is also lateral flexion. Plantar flexion and dorsiflexion are special words used to describe what happens at the feet. So when I plant my toes into the ground, that is considered plantar flexion. When I pull my toes up, that is considered dorsiflexion. The next couplet that we have is abduction and adduction. So abduction means to abduct or take away from the midline. So for example, that is shoulder abduction. To bring it back towards the midline is called adduction, to add back. Another example is at the hip, abduction, adduction. And we also have horizontal flexion and horizontal extension. So horizontal flexion, coming together, horizontal extension.
Don't use bullet points in a presentation. Look.
Sorry. Where he came from. That is the end of the video. Okay, bear with me. I'll just set this back up again.
Okay, so that's one of the 4 videos that we've got. The other videos obviously go into the other joint actions that we need to learn about. So circumduction, I'm gonna go through each one of them in a second now. But those videos, what I would advise is when you're watching those videos, actually stand up and do the movements along with the video. It just helps you to kind of embed that knowledge of what each of the joint actions are. Okay, so I won't play all 4 videos now, so you can watch those in your own time. But that's just an example of what's in the videos. So it's quite good because she splits it into flexion extension as one video and abduction and adduction. And in the next couple of videos, she'll go into more detail of different areas of the body and different types of movement that occur at different joints. Okay, so anybody got any questions on that or comments or anything? No. Okay, so let me just share my screen.
Okay, can you see that you should have the PowerPoint slides back up again? There we go. Okay. So have you got the PowerPoint in front of you again? Yeah, cool. Sorry. Okay, great stuff. Okay, so links to the 4 videos there. What I'll do is on the email that I send out, I'll put the links in the email as well as on the slide, so you'll have plenty of access to them. Okay. So our next section then we're looking at is joint actions. So from the videos, I'm just going to kind of explain the terminology when it comes to these joint actions. So when we analyze our joint actions, the starting point is the anatomical position, which is the position in the picture here. So standing tall, feet just outside hip width, hands, palms facing forwards and just down by the sides. So this is our starting point for all of our joint actions. We can also describe this position as being in extension. So if we look at the shoulder joint is in extension, the spine is in extension, the hip joint is in extension, the elbow joint is in extension, and the knee joint is in extension. So we're standing in an extension, the anatomical position. Okay, so our joint actions. So flexion, first of all, is usually forwards of the body. So when the elbow flexes, it's usually forwards of the body. When the spine flexes, it's forwards of the body. When the shoulder flexes, it's forwards of the body. Okay, let me just make sure you guys can see me. Okay, so everything is forwards of the body when we flex. Okay, so flexion is usually forwards of the body. The only exception to that is the knee, because obviously as we flex the knee will go the lower leg will go behind. Okay, so the joint angle decreases and extension is the opposite. So extension is where we go back up or go backwards into that extended position. Our exception to the rule is the knee joint, where the lower leg will come forwards to come back into that extended position. So if we look at the elbow joint, as we flex the elbow, the lower arm comes forwards. As we extend it, the lower arm comes backwards. If we extend the shoulder joint, the arm comes forwards. If we extend the elbow joint, the arm comes back. Okay, with the spine as well, we flex forwards or we flex back. If we look specifically at the cervical spine, we'll flex forwards and extend back up. Okay with that? So flexion, forwards, extension, backwards, except for the knee. Okay, so elbow joint, flexion, extension. Again, if I'm going too quick or you've got any questions on any of this, shout. So abduction and adduction. So as was mentioned in the video, so abduction away from the midline of the body, adduction towards and continuing across the midline of the body. So it happens at the shoulder joint and the hip joint. So abduction, to abduct somebody, is to take them away. Okay, so abduct away from the midline of the body, adduction towards and continuing across the midline of the body. So to add together. Okay, so abduction and adduction. The videos will obviously show you these movements a lot better than these pictures. Rotation, turning the hip in and out or rotation of the thoracic vertebrae. So when we rotate, we're rotating left and right, which is a rotary movement inward, which would be medial, or outward lateral. So if I use the shoulder joint, so we've got rotation inwards, rotation outwards. Okay, I don't know how well you can see that. So rotation inwards, medial, outwards, lateral, or simply rotating the torso, where we will rotate left and right. Okay, so that medial rotation and lateral rotation also can happen at the hip joint. So we can rotate the hip in, rotate the hip out, internal and external rotation. Okay. Circumduction, to circle part of the body. So for example, the ball and socket joints. So here is where we are causing circumduction, where we can go backwards and we can also bring it forward. So lots and lots of big movement around the ball and socket joint can also be done at the hip. Okay, so circumduction, so circling the shoulder or hip joint. It's not a great example of that picture. Horizontal flexion and extension. So this is where we are bringing the forwards. So horizontal flexion, also known as horizontal adduction, horizontal extension, also known as horizontal abduction, because we're in the horizontal plane. Okay, so our arms are horizontal to the floor. We're going to take them, or horizontal to the body, I should say. We're bringing horizontal flexion forwards, horizontal extension backwards. Okay, so also known as horizontal shoulder adduction and abduction, a forward or backward movement in the horizontal plane, drawing the arm across the body. Elevation and depression, so to lift and drop a joint. So mainly referring to the shoulder girdle. So we'll elevate and we'll depress the shoulder girdle. So elevation and depression. So shrugging the shoulders as the example. So our elevation as we lift the shoulder girdle up, and depression as we drop them down. Lateral flexion. So lateral flexion to bend sideways with the trunk or neck, and then lateral extension is to come back up into that starting position. So lateral flexion, lateral extension, lateral flexion, lateral extension. Okay. Pronation and supination. Okay, so pronation to turn the palm down, and supination to turn the palm up. Okay, so we looked at this when we looked at our joint, so our pivot joint. So pronation to turn the palm down, supination to turn the palm up. Okay, so the terms prone and supine are relevant to exercise. So prone would be meaning face down, or supine face up. So we can ask our client to lie in a prone position on the floor or a supine position on a bench to do different types of exercises. You might see some exercises written as like a prone fly, where you would be standing but in a prone position, so face down, and doing a fly action to work reverse to work trapezius and rhomboids behind. Okay, so reverse fly. Or for example, a supine chest press, where you're lying on your back with dumbbells or a bar and you're basically doing a bench press exercise, but you're in the supine position face up. So pronation and supination. Plantar and dorsiflexion. So plantar flexion, pointing the toes away from the body, and dorsiflexion to pull the toes towards the body. Let me just get this. So we've got plantar flexion. Oh, it doesn't move. Plantar flexion where we point the toes, dorsiflexion where the toes come up towards the shin bone. So one of the ways to remember this is, as was said in the video, to plant your foot, to point your toes. So P for point, plantar flexion, and then dorsiflexion as if you're going to stop a door. So you've got your foot against, so to stop that door from opening, you put your toes up. It's a dorsiflexion. Okay. Dorsiflexion and plantar flexion. Then protraction and retraction. So protraction is where the shoulders are drawn forwards, rounding the shoulders or rounding the upper back. And then retraction is where we take the shoulder blades drawn back and bringing the shoulder blades together and pinching in between the scapula. Okay, so protraction forwards, retraction back. Okay, protraction and retraction. Okay, that is pretty much this section. Okay, so it's a bit shorter, obviously, than our last one. But one more section I've got to do. Sorry, life course of the musculoskeletal system. Any questions on joint actions? As I said, it's really difficult to try and describe them to you over a Teams call, but the videos hopefully will help. Has anybody got any questions or queries on that? Okay. Right, so the final section then for skeletal system is the life course of the musculoskeletal system. So when we look at special populations, we need to think about the implications that exercise will have on those special populations. So we think about children, we think about the aging population, we think about pre-postnatal and disabilities. So for young people in the 14 to 16 age range, growing bone is not fully ossified, therefore it's vulnerable to damage. Avoid heavy, very strenuous or repetitive exercise. For pregnancy, so the stability of synovial joints is affected by the hormone relaxin and an altered center of gravity. So the hormone relaxin is released into the body to allow for a greater range of movement around the joint. So if we think about during childbirth, the pelvis and the hip joint needs to open up to allow for birth to take place. Now, relaxin can remain in the system up to 5 months after childbirth. So we need to be aware of that, and we need to think about the range of movement that that individual will have when it comes to certain exercises. So when we look at programming for somebody who is coming back after giving birth, avoid those high impact exercises and also avoiding fast changes in direction. We also might need to, not for everybody, we might need to reduce the range of movement on some exercises as well. So for example, if we're doing a chest press, for example, as we come back, we maybe not come back as far because of the range of movement around the shoulder joint. So maybe just coming back halfway and pushing forwards instead of doing a full range of movement on that chest press exercise. Hopefully that makes sense. But the aging population, okay, so potentially a decrease in bone density, so they could be susceptible to fractures. So the more weight-bearing exercise we can do from an earlier age will reduce the effects of that decrease in bone density. They may also have decrease in synovial fluid, so lubrication around the joint is not as efficient as it used to be. Could also have thinning cartilage, so there's reduced shock absorption and there's more friction in the movements. Less elastic ligaments and tendons and reduced joint stability. And also think about if anybody has had ligament injuries in the past. So me for one, so I've had ligament damage in my ankle. So it's not as good as it used to be. So the stability in my ankle joint now, I've got to really think about the activities that I do because I can roll my ankle really easily. So we think about that as people get older as well. And work on a case-by-case basis with individuals, but bear the changes in mind. Not everybody will be affected by these things through age, okay? There are a lot more active people nowadays, which is great. So these effects won't be as prominent as they used to be, if you like, okay? But obviously, yes?
A quick question as part of the aging population here. Decreased synovial fluid, decreased bone density, etc. As you get older, if you do more exercise, will that increase the synovial fluid, or are you stuck with it? Is it going to improve your cartilage? Is it going to improve, or is it just going to sort of assist you along the way? Will it increase as you do more exercise is what I'm asking.
So whether it will increase or not, I don't know. But what you're going to do is you're going to slow down the decrease, if that makes sense. Yeah. So, and this is what we're trying to promote now is the earlier people can be active, it will reduce the effects of this. Now, if somebody kind of comes to you at a certain age and says, "Okay, I haven't done any exercise all my life," and suddenly, you know, at an older age, they want to get into activity. Obviously, we want to promote that, but what we might find is that if they have got a decrease in their synovial fluid, to increase it again is going to be difficult. But by doing more activity, it means that the synovial membrane will wake up and secrete synovial fluid into the joint. So it's not going to kind of, what's the best way to describe it? It's not going to get worse as quick, if that makes sense. So the more active they can be, the more lubrication will be around that joint. But when
it's
it
going
comes
to
to
slow down the inevitable.
yeah, yeah, exactly. It's going to happen to us all. But the more active we are, the longer we
longer
will
it will
be
take.
more,
Yeah.
supple and the more synovial fluid we will have. So it's all about trying to kind of get people active earlier to reduce the effects of the aging process on the skeletal system and on joints. Okay. But then again, like, you've got people who've been active all their lives. And then all of a sudden, osteoporosis starts kicking in, which is kind of maybe a more of a genetic thing than a lack of activity thing. Okay. But the more active we can be, so we've got, you've got groups that will do, excuse me, exercise sessions. And because they are more active, you will see them on a day-to-day basis. So the functional ability is what benefits more so than like, trying to run marathons or things like that. It's the functional benefit that they will get out of it rather than a fitness benefit. I don't know if that makes sense. Yeah. So that's kind of what we would look to do. So if we've got somebody who comes to you and says, okay, I haven't been active, but now I want to get active, it's more about being functional than achieving, 1 rep maxes and things like that. Okay. Cool. So again, work on a case-by-case basis. Your client interview, you will be able to kind of identify a lot of these things from the client interview and doing some basic fitness testing with them as well. Okay. For disabilities, so limitations will be specific to the disability. So depending on what that disability is, will depend on what limitations are caused by the musculoskeletal system. So we've got physical disabilities, which will obviously affect the skeletal system. We've also got neurological disabilities, which will affect the skeletal system. Working on a case-by-case basis, but also working with their medical professionals. We can incorporate different activities, different exercises to include in exercise sessions and activity sessions. Best person to ask again, and I mentioned this yesterday, is the individual themselves. What can you do? What are you limited to doing? And then incorporating and trying to get new ideas to get them more active and moving more. Okay. But again, we could kind of do a whole course on disabilities. But if you do come across somebody with a specific disability, don't be afraid to ask them the questions, and don't be afraid to go to their medical professionals, whether it's a physio or whether it's a consultant, GP, whoever, to get more information to include them in your sessions. Okay. And that is the end of that section. Any questions or comments or anything on anything we've done? Nope. Okay, so I'm just going to stop this recording.